I'd like to thank everybody, or thank the committee for allowing me to come to speak on one of my newer passion projects, physical activity in children with kidney disease. What I first want to kind of introduce is those slides I provided you have a lot of content on them, and I just want to make sure that you have the information. There may be a couple slides that I skip for brevity's sake so that we can stay on time, but surely if you have questions later, feel free to ask. Since I'm speaking to a group of dietitians, I really wanted to start the session off by a quick review of physical activity definitions so that we're all on the same page as to the terminology that I'll be using through the talk. So physical activity is any bodily movement produced by skeletal muscle contraction that substantially increases energy expenditure. And exercise is a subset of that, which is planned and structured. Now, when we talk about pediatrics, we really don't necessarily always talk about exercise in that setting because from an age-appropriateness, it's not always age-appropriate at every level. Then we talk about physical fitness, which are the attributes that people possess or to achieve the ability to perform physical activity, and it's comprised of skill-related, health-related, and physiological components. There are 5 primary health-related physiological components, which are body composition, flexibility, muscular strength, muscular endurance, cardiorespiratory fitness. I've highlighted this one because it's one of the biggest ones that I think are really important, which is the capacity of the cardiorespiratory system to supply oxygen to muscle mitochondria for energy production during activity. And then you also have your skill-related fitness measures, which are agility, coordination, balance, reaction time, power, and speed. And you'll see these more used in sports. Sometimes you'll see a little bit used in elderly care with falls like coordination and balance. There are different categorizations of individuals as far as how much activity they achieve a day. So highly active, per week. Highly active is categorized as greater than 300 minutes per week of moderate intensity exercise or 150 minutes of vigorous intensity exercise per week. Active is 150 minutes of moderate intensity or 75 minutes of vigorous activity per week, and insufficiently active is basically anywhere between 0 and 150 minutes per week. Now, of course, you can get like a combination of moderate to vigorous, whatever that equivalent looks like. I talk a lot about intensity in this talk, and so intensity is measured as metabolic equivalents. I'm sure you guys are familiar with these. But it's basically the amount of energy used by the body compared to resting metabolism, and it's calculated based on oxygen utilization by the muscle. So one metabolic equivalent is the equivalent of just sitting quietly. Other intensity measures are light, moderate, and vigorous. And then sedentary is that behavior during waking hours while sitting, reclining, or lying posture with lower energy expenditure. Oh, and physical function, the ability to perform basic and instrumental activities of daily living. So hopefully you don't get those two confused. Physical function is different than a lot of other things. Okay, so here's your next intro. What are the current guidelines for physical activity for children and adolescents? These guidelines were taken by the World Health Organization, and they're pretty much really close to guidelines that we use in the U.S., although they're very specific for children less than 5 years of age. So most of the stuff that I will be talking about won't really focus on this category, but in the less than 5 years of age, you're looking at tummy time for infants, decreased restraint time, so limiting time in carriers, strollers, and high chairs, limiting screen time, or just good quality sleep as well. And there's really not much discussion on intensity here, except for the introduction of that over the age of 3 of moderate intensity activity. Now, the guidelines that we'll be focused on are really going to be focused on 5 to 17 years of age, where it's recommended that children achieve 60 minutes daily of moderate to vigorous physical activity, mostly aerobic, and start to incorporate vigorous activity as well in their aerobic activities. This activity also includes muscle and bone strengthening exercises, which can end up being moderate to vigorous at some point as well. And then again, that limit of sedentary time and recreational screen time. And then for any children not meeting activity guidelines, it's recommending a gradual progressive increase in activity, and these can be done in smaller bouts as they are beneficial in increments throughout the day. Just to get a better idea of what moderate and vigorous physical activity look like for you guys and how that equates to metabolic equivalence. So you have, I really want you to focus on the moderate to vigorous, so that's 3+. And what that looks like when we're assessing and when I'm educating children and adolescents on physical activity intensities, I find it more important to really ask those symptomatic questions, as some of our patients may be so deconditioned that the activity examples listed are more laborious for them to perform. So I like to use the talk test when they're performing any kind of activity. Is it difficult for you to talk while you're doing XYZ activity? So that kind of gives you a good idea. Now, muscle strengthening and bone strengthening can be also interdispersed depending on the load and the frequency. And so that's why it doesn't really tell you what metabolic equivalent it is, because it can be changed. So another method that we use to assess physical activity intensities are rate of perceived exertion scales, or RPEs. In adults, you'll see this on a 6 to 20 point scale, and it's more related to heart rate. But in children, we like to use a little bit more of that 0 to 10 scale because it just makes a little bit more sense to them. And again, your moderate activity is about a 3+. And then it's also really useful when we're talking about any of our patients that may be on beta blockers, where their heart rate response to physical activity may be blunted with increased workload. So what does the literature look like for physical activity and exercise in children with CKD? I'd like to say it's understudied, like most everything else here. We lack objective measures of physical activity. We rely mostly on survey measures of activity and pedometers, which aren't not that accurate. But what is really obvious is that we have very high levels of inactivity and high levels of screen time. And unfortunately, that inactivity level is cyclical, and it compounds the negative consequences of no activity. So when we talk about this inner blue circle, we're talking about just basic cycle of inactivity. You have decreased physical activity, which leads to decreased anabolic stimulus, which further decreases muscle mass, increases fat mass, decreases cardiorespiratory fitness, decreases neuromuscular fitness or function. That further goes into decreased functional capacities, decreased quality of life, increased frailty, increased sarcopenia. And then, of course, you have barriers you have to consider. So if you're already low and you don't feel like exercising, where's the likelihood that you're going to exercise more? And then this outer circle kind of talks about where CKD falls in this. And CKD, there's fatigue, uremia, inflammation, anemia, poor nutrition that can contribute to any part of this cycle as well. So unfortunately, our kids are working against a lot once they become extremely inactive. So it's my goal today to kind of win you over and talk about all the possible benefits. Not all, but there may be a few missing. But hopefully you'll see. So cardiovascular health. We all know that cardiovascular disease is a major cause of death in our patient population, and that high mortality is maintained even after transplantation. So higher cardiorespiratory fitness values are the key to actually improving cardiovascular risk in healthy individuals, both children and adults. And in studies in adults, we've found that if adults have higher cardiorespiratory values, they have a lower mortality risk, irrespective of body composition, LVH, or left ventricular hypertrophy, and blood pressure. So it's beneficial regardless of some of those other aspects. And then, let me see. Whoa. Where's the little laser? So this graphic on your left that you'll see is basically a review of exercise testing in pediatrics with a variety of pediatric chronic diseases. So they basically took a bunch of data and then summarized them in various diseases. And I want you to see this one here is your ESRD population. So our children with end-stage kidney disease have the lowest cardiorespiratory fitness values compared to spina bifida, leukemia, juvenile arthritis, osteogenesis imperfecta, cystic fibrosis, cerebral palsy, hemophilia. So our patients are at massive detriment here. And physical activity is really the only way to improve cardiorespiratory fitness. What we also know about our patient population, so these are cardiorespiratory fitness values measured by VO2 max. The graph on your left is comparing controls versus CKD stage 2 through 4, so it progressively gets worse with disease progression. And then the thing I want to call out on the graph on your right is that there's really a lack of improvement after transplantation. So dialysis is definitely your worst values, but transplant only brings you up so far. It doesn't take you back to control values or CKD values. Okay, so in this study, it was, again, most of these are small studies. It's like an N of 16, healthy controls 36, a small cohort of children post-transplant, and then children were grouped according to their weekly amount of physical activity. So your control group greater than 3 hours, less than 3 hours, and then transplant less than 3 hours and greater than 3 hours. Oh, too many buttons up here. Cardiorespiratory fitness and left ventricular mass is worse with lower amounts of physical activity, regardless of whether you're a transplant or you're a healthy control. However, our transplant patients fare worse regardless, because when you look, physical activity is effective at reducing left ventricular mass and increasing cardiorespiratory fitness values, because this graph on your left is going to be mass, but you see similar patterns in the cardiorespiratory fitness. So those who, let me see, boop, okay. Those who had more exercise, greater than 3 hours, had better function and better respiratory fitness. Same thing with your transplant patients. Those who had more than 3 hours of activity had greater cardiorespiratory fitness and lower ventricular mass right there. And unfortunately, though, what you see is there's no difference between your sedentary controls, so controls who had less than 3 hours of exercise, and your transplant patients who had more than 3 hours of exercise. So when we're talking about that, transplant patients are worse and they require more activity to be just similar to healthy controls. Okay, physical function. So remember, this is the ability to perform daily activities of daily living. So this graph on the right is really, on the right. You usually see this in elderly populations where they'll graph physical function, and then with decreasing age, you will see a plateau at a certain point in age, and then over time, it'll just slowly decrease. And now physical activity can actually improve this, where you see it can mitigate that loss. I'm going to go back, yeah. But I would argue that in our population, they don't have that peak same peak that you would see physiologically, because they start out with kidney disease early in life and they have a lower reserve. So they may start out down here. And so physical activity may be really important earlier in life to peak physiologically and peak functionally as much as possible. But what we do know in CKD and dialysis and transplant is functionally they're worse. Lower gait speeds, 30% lower 6-minute walk distances, anywhere between less than 1 to 4 standard deviations below age expected means. And so as Noni was talking, my biggest concern here is sarcopenia, right? One of the key measures is decreased function. And then this also increases the risk for frailty as well. So physical activity does have the potential to improve function or limit the decline in children with CKD as well. All right, health-related quality of life. So in Interestingly, physical activity is really important for quality of life as well. So in children with renal transplant who have a lower quality of life, they report lower perception of sport confidence and lower physical conditioning. So it becomes a really difficult patient population to actually encourage to do activity if they have lower sport confidence. But we do know that in CKD, transplant, dialysis, higher physical activity or higher daily step counts leads to higher health-related quality of life, specifically in your physical activities or your physical subscales. And then in exercise interventions, those who have improved activity improve those subscales, and there's one study that's actually shown improvement in all subscales. Okay, so physical activity is also beneficial for musculoskeletal health. You need physical activity as an anabolic stimulus to promote muscle mass or maintain it. So we all know that muscle wasting is pretty prominent in our patient population, and we see this redistribution of body composition with disease progression, specifically with this drastic lean mass loss in extremities, primarily contributing to whole lean mass losses. So you'll see in this graph up at the top, you have this drastic whole body lean mass loss, but that is driven primarily by extremity lean mass loss, right? And so when you look at this compared to fat mass in these patient populations with decreases or advances in kidney disease, there's actually marginal fat loss. But proportionally, if your patient loses weight on the whole, you're likely having a higher percentage of fat mass. I think there's a big concern here that I have, and what does this look like when we're just looking at anthropometrics? Because it probably isn't telling the whole story. So, strength. Multiple studies that definitely show that in addition to wasting, our patients have lower relative strength compared to other chronic illnesses. And then even as disease progresses, just like the rest of the story I've told, your strength or their strength becomes lower. So this one, this graph on your right is a graph from the CKD cohort where they compared hand grip strength to of CKD 2 plus compared to 1, and they do get lower with CKD progression. Not only that, lower total body strength was associated with lower frequency of physical activity and less than 10 minutes of vigorous physical activity a day. So when we talk musculoskeletal health, I think it's a really good segue into metabolic health, as the muscle is more than just an organ of locomotion. When we think about it, muscle can really improve muscle health can actually improve insulin sensitivity. So with high sedentary time, insulin sensitivity decreases, and we've already talked about those high risk of our patient population, the high risk of metabolic syndrome. This is a meta-analysis of healthy children, about 3,000 plus healthy children. And they found that physical activity is a key component to modifying metabolic risk. So they found that for every 10-minute increase in moderate to vigorous physical activity, there's a 12% decrease in the odds of developing metabolic syndrome. Furthermore, for every 60-minute increase of sedentary time, there's a 28% increased odds of developing metabolic syndrome. Mentioning the CKD study that I believe Noni was mentioning, there's a high prevalence of metabolic syndrome in children with CKD. And what's more important is that metabolic syndrome, we know it includes that definition of overweight and obesity. However, this graphic on your right from the CKD study actually separated it by normal BMI and rate, and then obesity and overweight, and then rate of decline in GFR, and found that normal BMI plus your incident multiple risk factors, those cardiometabolic risk factors, and persistent metabolic syndrome all led to a 2 odds faster rate of decline in GFR, regardless of BMI. Okay. I'm going to skip this one, but basically, uremia limits oxidative metabolism in children with kidney disease. This is very important from an energy demand perspective and exercise perspective. Okay. Noni mentioned this a little bit earlier, or alluded to it, but I think it's really interesting because it's an increasing area of research in physical activity and chronic inflammation, where chronic exercise promotes an anti-inflammatory environment through increases in IL-6 release from contracting muscle. Now, IL-6 sounds bad, but it really depends on where it comes from, because it will signal downstream reductions of macrophages and adipose tissue infiltration, which further leads to reduction in pro-inflammatory cytokines like TNF, and then increases those anti-inflammatory cytokines like IL-10. And so we all know kidney disease is associated with chronic inflammation. And there's some preliminary studies in pediatrics that show the effects of acute exercise can create that anti-inflammatory environment as well. And now this study here that I'm showing you on your right is really a study of adults it was an intervention study for adults with CKD, where they performed 30 minutes of moderate intensity walking, just like a brisk walk, 5 times a week for 6 months. And they actually found improvements in your IL-6 to IL-10 ratio compared to their healthy controls. And so exercise may also counteract the effects of what kidney disease is already just inherently there doing. So physical activity and blood pressure, I think we're all aware that optimal blood pressure control can slow the progression to end stage. Now, this isn't, I'm going to be drawing a lot of conclusions here that aren't always, haven't really been studied in the CKD literature, but I'm going to make the case that it's important. Okay, so this is a study of almost 10,000 healthy adolescents, and it was observed that there's basically a dose-response relationship between moderate to vigorous physical activity, time spent, which is your x-axis, and systolic blood pressure control, HDL, BMI, and VO2 max, which is your cardiorespiratory fitness. So it's possible that moderate to vigorous physical activity could have a moderating effect on blood pressure control and therefore hold importance in disease progression. So conversely, let's talk about blood pressure and sedentary time. So in a school-based intervention, again, this is a healthy control intervention of 8 to 10-year-olds. The authors reported that there was decrease in blood pressure response, reported blood pressure decreased in response to moderate to vigorous physical activity. However, it wasn't different from controls. When they did a further analysis, they determined that the moderating effect was only present when sedentary time was less than 11 hours a day. That's a lot of sedentary time. So if you think about our dialysis patients who sit on a dialysis machine for 3 to 4 hours, 3 times a week at least, maybe, that's a lot of their day taken up by dialysis and sitting. So it's kind of, sedentary time is really an important intervention that we have to consider along with physical activity. Okay, so talked a lot about basic benefits of physical activity, but there's a lot of barriers to our patients in how to perform physical activity and what to do. I think the first barrier we have is how to identify risk. So what's recommended is the use of what's termed a physical activity vital sign. It's basically a 2-part question. You ask how many days a week do you engage in moderate to vigorous physical activity, and then on average, how many minutes does that session last? And then you multiply it, and then you come up with the total minutes per week. However, so you would then compare that to, is it the equivalent of 60 minutes per day, 7 days a week, or 6 to 7 days a week? However, it's infrequently used. At least from what I've seen in the U.S., it may be more useful outside. But also, when we talk about specialty populations, I don't know about your center, but we often act like the primary provider in most of their care. And then if these children have other pediatricians that are involved, they just defer to us, but we don't know that they're deferring to us, is another problem. So physical activity assessment is infrequent, and then when it is assessed, it's actually not numeric, where we can't compare it to where it should be. So our own data at our own institution has showed that Less than 60% of our patients in our CKD clinic receive a physical activity assessment. And when it is done, it's very vague and it's very general. It's not descriptive enough to know that these patients need counseling. And then of those 60%, 50% of those actually receive counseling. This has actually also been shown in kidney transplant patients. So the study by Wolf showed that 70% of patients receive physical activity after transplant, but really only 45% of them are encouraged to be physically active. So if we're talking about obesity rates, metabolic syndrome rates, this number should be higher. And what was spoken more about in those, which is appropriate, is topics related to avoidance of contact sport or contact sport education or protective gear in that transplant setting. 100% appropriate. Safety, right? The big elephant in the room. Right now, so I'm going to go through some of the intervention studies later, but there are 7 intervention studies that I have found, and none of them report adverse events. I think that's a key point. And then the first and foremost, most primary thing that we need to think about when we're talking about physical activity is their cardiovascular risk. That's primarily led by blood pressure control, and is usually the limiting factor in safe participation and avoidance of cardiovascular events during exercise. So if your patient has uncontrolled hypertension, you need to get their hypertension controlled with medications before they can do any exercise or refer them out. There's also concern for fracture risk. So, but I would say the blood pressure control and the fracture risk are kind of a double-edged sword. So if physical activity improves both, but we limit it because they're not controlled, where do we intervene? So I think that's where it becomes more difficult, and we have to create more of a team approach about what's appropriate and what's not appropriate for them. I will also say, as I'm performing a study right now, I think what I usually see is my physicians are I always ask them for medical clearance regardless, and it's a lot about, well, how intense is this exercise? And I like to say, well, I'm not going to make them go run a mile if they can barely walk 10 feet. So it's that idea, too, that technically all of this activity is progressive. And then we also have to think about that perception from families on my child is too ill to do this. And that's not necessarily the case. So I will, lean on historical literature and the things that we've learned historically about cancer treatment, HIV. 40 years ago, we recommended rest. And that's not the case at all. Now we recommend as much physical activity as is possible during treatment for chemo, after treatment. These patients are living longer, and so you really have to adjust those or address the chronic disease development as well. And one resource that you can use is the Physical Activity Readiness Questionnaire that any discipline can actually perform on a patient to actually identify, it's used as a safety screen where it reviews family history, disease severity, and it's really kind of this screen for cardiovascular issues for the most part. Okay, so now I'm going to go into these 7 intervention studies so far published to date. Really high level. So there's most recent one is 2023 article in CKD population, a 6-week intervention 2 times a week, and it was exergaming, so like video games, but movement or home-based controlled. And we found that it improved quality of life metrics and functional metrics. This 2020 article in transplant patients, also exergaming intervention. This one was 30 minutes per session and then 3 sessions per week, and they actually saw no improvement. This 2019 one that focused on stage 3 and 4. kidney disease, and it's really the only true resistance training plan or intervention that's been reported in the literature, but also found improvement in physical function. And what's really interesting about this particular study is that the standard care group actually decreased quality of life. So I think that's important to take into account in the disease progression as well. And then we have Fabio's study in 2014, which was in dialysis patients looking at interdialytic exercise with a cycle ergometer, 30 minutes, 2 to 3 times per week for 3 months. Also showed increased physical function parameters. And then 2014 study in CKD, dialysis, and transplant, which was a 12-week educational pedometer intervention. And they actually found no improvement by group. And then also an increase more in physical function characteristics and quality of life. And then this 2009 study, also interdialytic exercise 2 times per week for 3 months using cycle ergometer for 30 minutes and then resistance bands for another 30 minutes. Also showed increase in more functional metrics. And then this 2009 study, I want to highlight that this study was very much more specific than the others, where it was a 2 times per week, 12-week supervised exercise training program to achieve 50 minutes of moderate intensity exercise at a heart rate peak of 55 to 90%, and resistance exercises. And this is the only study that actually showed improvement in exercise capacity or cardiorespiratory fitness. So let's talk about outcomes that weren't improved in these studies, because these studies didn't just take functional metrics. Body composition wasn't improved. I have theories behind this. When you look at adult guidance on how much activity it takes to lose weight or change your body composition, it is exceedingly high. We're talking upwards of 400 minutes of activity a week, moderate to vigorous physical activity. So I don't think it's an ideal metric that we should be aiming for in our population, to be honest, or outcome metric that we shouldn't be measuring for. Additionally, structure and function of cardiovascular changes. I would also argue that you need improved cardiorespiratory fitness to actually fix this. And again, nobody's looking at this, and none of those studies were designed, except for that first one, to improve cardiorespiratory fitness. In total, those studies are about maybe 100 patients, so it's a little low over the last 10 plus years. But the biggest problem in these studies is intervention adherence. Their reports are 30 to 70% attrition rates. This is crazy high. And I think more of the issue is figuring out how to get past this. When you delve into these studies, what they kind of talk about is patients will say is lack of time and motivation. Sometimes it was descriptive, saying it's linked to the disease, but there's no further explanation as to what that means. And then there's also, I find it a funny way to describe a patient as saying, literally, it says, the excuses were. I can't say that our patients would, excuse sounds negative, but I think it's a little bit more nuanced than an excuse. But fatigue, musculoskeletal aches and pains, those can actually be fixed through physical activity. And then perception of exercise is boring. Well, yeah, like age-appropriate guidelines indicate that you should make it fun. And then participation in exercise in school. I don't know about the rest of the world, but in the US, that participation really isn't enough to meet just daily guidelines. And then another issue was parental investment in the program. If your parents aren't involved, you're not going to get physical activity, your children involved in physical activity. That's just across the board. And then I'd like to kind of posit that clinician investment is also an issue as well. Whether or not they believe that it's important, or there are other barriers that contribute to not being able to discuss it in a clinic setting. Are you able to even identify it? Is time an issue? And do you have anybody in the clinic setting that can actually address it? Okay, so what are the recommendations for children with CKD? There aren't really any, but I would say the obesity CPR, or obesity metabolic syndrome CPR, is pretty close to just very general. You have to adjust intensity and duration. And when we talk about exercise prescription, we're really talking about FIT-VP, which is how you prescribe exercise. Frequency, intensity, time, type, volume, and progression. So you could just revert to general pediatric guidelines, or you could attempt to adopt some adult CKD guidelines. So what do those look like? This is from the American College of Sports Medicine. But generally, you're trying to achieve normal guidance of healthy individuals, but you have to progressively work up to it, right? So you start at lower intensities, and then you start at lower amounts, and you slowly work up. The key issue that they usually identify here is, aside from starting at lower intensities, when it comes to resistance training, it's not recommended that you do exercise testing at 1 rep max for that, and just for the fracture risk, and you estimate based on 3 rep max. Okay, special considerations. So when we're talking about dialysis populations, what do we consider? You have to consider dialysis day. That's the biggest issue. These patients are already fatigued, especially in the adult population. They may have more blood sugar changes, so sometimes they recommend a snack. I'm going to mention RPE scales because that's going to, your heart rate response in our patients may be different based on their medications and just their cardiovascular health. And then, of course, if they have a fistula or graft, you want to be careful with resistance training or any weight on that arm, as that could injure it. If you're doing interdialytic weight gain, they recommend exercise at the first half of treatment because hypotensive episodes are more common in the second half. And then really that intervention of breaking up sitting time, coming up with sedentary time interventions. Home hemo, they actually recommend very similar to regular guidance, regular healthy guidance. Peritoneal dialysis, this is specific for continuous ambulatory peritoneal dialysis. So it really just talking about discomfort of the dialysate within the abdomen, and they may need to exercise with less in their abdomen if it's uncomfortable. And then the only recommendation on renal transplant is really to, in the time of rejection, to decrease intensity of exercise, but it can still be continued. So what can a dietitian do? So let's talk about scope. You can evaluate physical activity habits. We can determine readiness to change. We can educate on the benefits and the role of physical activity in prevention of and treatment of chronic disease and their current disease. And then if physical activity clearance isn't provided, you can always conduct the safety screening using that PAR-Q questionnaire, which is really easy to Google. You just pull it up. And then you can refer back to the physician if they need medical clearance. I think our role as dietitians, especially already integrated into the nephrology setting, is really important, especially as it relates to behavioral modification. We are kind of set in a spot where I think it might be more of our responsibility at times to kind of really educate on these principles. And really, if patients are medically cleared to do exercise, have no medical concerns, especially from a cardiovascular standpoint, we can continue to recommend normal, healthy age requirements for physical activity. There's nothing that says that we can't. And I think what's really important to think about is, in the nutrition world, we are shooting for optimal age-appropriate growth. I think in the physical activity world, we should be shooting for the same, because all of the data in every other area supports that more physical activity is better. Aiming for those higher numbers, even in healthy individuals, is better. And in your chronic disease, that's what it's shown as well. And then ultimately, if you're uncomfortable, I think we have to consider referring to certified exercise professionals as well. Now, I don't know if this varies country to country, but in general, what I've seen is the limits of guidance that an RD can safely provide without additional training is inclusive of fitness assessment, exercise prescription, design of specific exercise routines, and then supervised physical activity or fitness training schedules. So in summary, physical activity should really be viewed as an integral component to the treatment of children with CKD, not simply as health enhancing. And I think this is just a problem overarchingly in a lot of in normal, healthy individuals, where more physical activity is just going to make you healthier. But no, we should say physical activity is the norm, and we should shoot for that. And then I've already gone through all those benefits on what physical activity has the potential to offer our patients. And it's likely, I think, that beneficial effects outweigh the safety concerns. And more importantly, again, from a behavior modification standpoint, we are very well placed to especially discuss these negative effects of inactivity and coming up with behavior modifications to decrease sedentary time. There's no limit on that from a dietitian role as well. Okay. That's it.